Okay, I think we're going to get started here pretty quick. I want to now introduce you've met some of the doctors already, but we've got some new faces for some of you for our panel now. Dr. Aronson is a professor of urology from UCLA and is a specialist in diet. He chaired the diet session. Dr. Gill runs the robotic surgery program at USC. He's the chairman of the program there. Dr. Richard Lamb is a medical oncologist and hematologist specializing just only in prostate cancer. And Dr. Mark Botnick is a radiation oncologist trained at Memorial Sloan Kettering and who has specialized in implant, is an excellent skilled in radiation implants. So, and you know Dr. Strum and Dr. Myers and Dr. Bond already. So one thing, feedback we got last year is we were going to get through more questions. We have some clinical cases if we have time to get to them. So what I thought we'd do, you all submitted a number of questions, is that just to move quickly through this, we'll give each of our doctors one or two quick questions. Hopefully they can give us concise answers because we have 30 or 40 cards here if we can get through them. So we'll take them one at a time real quick, and then after we get through and everyone has a chance to say something, we'll just throw out some questions for the whole panel to discuss. So I'll throw one here to Dr. Lamb first. That what do you recommend, or how do we reduce the toxicity of chemotherapy?
So the main side effects of chemotherapy that we got to worry about is tiredness and nausea, and sometimes nausea, tingling in the fingers and toes, and changes in taste buds, and effects on the blood count. So I'll just briefly go through most of those if I can. So with regards to blood levels, sometimes we require, if for example the white cells go low and causes infections, we do have to use medications to prevent the white cells from dropping. There are medicines for anemia to prevent anemia, which results in fatigue. And fortunately, there's a lot of new medicines that make chemotherapy-induced nausea much less of an issue now. And finally, with side effects related to taste buds and fingernails and numbness and tingling, we found a lot of success when patients get taxotere chemotherapy, for example. We have them actually hold on to some ice, and that seems to diminish the side effects of taxotere on fingernail pain and numbness. With regards to taste buds, having patients having some ice on their tongue, icing down their tongue seems to reduce the decrease in food, the numbness and decrease in taste sensation associated with chemotherapy. And there's some other moderate side effects that over the years we've come up with some effective treatments. And finally, the most important intervention is actually knowing when to take a break from chemotherapy. So if you get a nice response after 4 to 6 treatments, we try to limit the duration of chemotherapy and take a break as soon as we feel that it is safe.
Thank you very much. Dr. Strum, what's the relative value of MRI SPECT versus color Doppler during proactive surveillance?
Are you asking for a comparison of one versus the other?
Yep.
Well, sometimes the MRI and the MRI spectroscopy shows things that the color Doppler ultrasound doesn't, and sometimes the color Doppler ultrasound shows things that the MRI and MRS doesn't. Although, if you speak to those who are truly focused on one or the other, they'll tell you that one shoe is all you need. I'm a big believer that you don't hang all your coats or hats on one hook. So, for me, it's an issue of really the selection of the artist, the availability of high-quality ultrasonography. So I try to refer patients to a a true artist in the field of ultrasonography, or I try to refer patients to a imaging center where they do excellent work with MRI, MRS. I don't really feel that there's one that's greatly better than the other.
Thank you. Dr. Gill, is there a risk of lymphedema from extensive lymph node dissections?
Extensive lymph node dissection during robotic or any prostatectomy essentially takes the lymph nodes that are in the obturator fossa and along the internal iliac chain. These are not the lymph nodes that are drained into by the leg. So typically those are the inguinal lymph nodes, and that's an entirely different field of lymphatic drainage. So typically after extended lymph node dissection, lymphedema of the legs is not something that we see.
Thank you. And Dr. Botnick, is proton beam radiation better than IMRT? I got 3 or 4 of those, so.
No.
Okay. Thank you. I appreciate short answers. That's good.
Well, I'll just add this, is that...
I knew he couldn't resist.
Yeah, I can't resist. Really, the efficacy of radiation treatment is born partially by image guidance to make sure that you are hitting the area that you're intending to treat, and number 2, by the dose. So if, as Dr. Roach alluded to yesterday, that if you are treating people to the same relative dose between IMRT or protons, the outcomes should be the same. If you review what's been published, the results look the same, both in terms of cancer control and in terms of side effects.
Thank you. Dr. Aronson, how important is diet for prostate cancer patients? I think it's specific. We know diet's good for overall health, but for the prostate cancer itself, is the diet going to make a big difference? When you ask someone who knows the answer, they think a lot.
I think that I think personally that diet is important. I think it's extremely important. Although no level 1 studies are out there that clearly prove it, these types of studies where you have men who get a specific diet and men who don't, and you look and see what if the endpoints are different between the groups. That being said, I think there's abundant data that suggests that it's potentially important. And we talked in our session about a number of possible dietary components that are important. I think the colorful vegetables and fruits, I think the fibers that you get from those, I think that for men who are obese, I think there could be some benefit for weight loss. We talked about, I think that when you're eating fats, I think the healthier fats that we're seeing now are the fats from fish oil, the omega-3 fatty acids may be beneficial. To answer a couple of questions real quickly from the session that I had a chance to think about some more and look up, there were a lot of questions about what's the best oil to use for baking. And you know, there's some concern that I have about corn oil. I think the best oil for baking really is canola oil if you have to bake and if you're going to be making baked foods. But I think the best approach is there's recipes that that replace the oils with applesauce. And I think if you can pursue those, that's a way to reduce the fat levels even more. The one other comment I'll make is there were questions about what's the best milk to drink, and is milk bad? Now there's some studies that suggest that increased milk intake may increase the risk of prostate cancer, advanced prostate cancer. I think that's probably from the high fat content within the milk, but I think your healthiest milk choices are going to be like an organic, non-fat milk, and you could possibly alternate that with a non-fat soy milk of some sort. And so that, I just wanted to give a little more clarification on that.
Thank you. Dr. Myers, what about vitamin E and selenium? There seems to be recommendations on both sides of using these additives.
Well, it's controversial now because the SELECT trial suggested a lack of benefit, but I'm among those who think that trial was poorly designed and poorly executed and uninterpretable. But my reservation about selenium arises from the fact that several studies now show insulin resistance and an increased risk of diabetes. The numbers are small but real. And this is already a problem in men on hormonal therapy, so I've gotten nervous about the use of selenium and looked at other antioxidants that might have a safer profile. Vitamin E is a similar problem. At higher doses, there's a bleeding risk. And that was a real question with vitamin E, is what's the dose of vitamin E that you need for anti-cancer activity and doesn't cause a bleeding risk? And I'm unsettled about that issue. So I've used other antioxidants at present than those two for that reason. If those problems were solved, I'd go back to selenium. I think that one thing about selenium is that you can have your blood level measured, and if you're selenium deficient by blood test, you obviously need to take supplementation. And there are parts of the country where selenium deficiency is quite common. One of those is Virginia, the other is in the Pacific Northwest, areas with high rainfall and acid soils.
Okay. Dr. Bond, are there any preliminary results from the critical trial?
Yesterday, I shared with you that my experience based on Manila patient population, and then after that, we have a former FDA-approved clinical trial going on. It is more of a dose escalation and safety study. First group of men, 3 men had only 25 million dendritic cells infused right after cryoablation. And last week, I have the first patient of second tier, that is, he got 75 million cells. And then it's too early to report you the result, but unfortunately, one gentleman's PS came down from about 50 to 10, and then I started going back up, and then a little bit fluctuated, but unfortunately, there might be some elevating trend. But other 2 gentlemen, I believe that one of the gentlemen's PSA started with about 570, and then 2 weeks later, about 370, and then down to 180. Now it's about 80 something. And other gentleman, his PSA was not that high, and it's also going downhill very rapidly. So I hope that those 2 men keeps that kind of a PSA trend, and then we just remains to be seen. And then we will add 2 more gentlemen with 75 million cancer cell dendritic cells, and we have to wait 1 month to make sure that there's no toxicity, anything like that. We have to stop the procedure. I hope not. I don't think we will have, but after that, our goal is that we will have patients, 27 more patients with 100 million dendritic cells will be infused to the cancer site.
Okay, thank you. All right, so let's now throw some questions to the whole group. Many people sent in questions asking about where HIFU stands for newly diagnosed men with prostate cancer. Just throw it up into you guys, and anyone want to speak up on if they think HIFU has a future? Does it work? Is it a bad thing? Is it where are we at with HIFU?
I'll take a first crack at it. So high-intensity focused ultrasound has been used in Europe for over 10 years. Over 20,000 patients have had treatments from it. The cancer control issues from HIFU appear pretty good. PSA nadir down to the HIFU in and of itself doesn't seem to work as well unless it is combined with pre-HIFU TUR. So the point is we're trying to ablate prostate tissue with focused ultrasound beams being delivered transrectally. And if the prostate is smaller, it seems to work better because you can target more of the prostate gland. So the earlier concerns about obstructive voiding, about stricture disease, about PSA not really nadiring to in the undetectable range have been improved by doing a pre-HIFU TURP. These are data from Munich, which is arguably the world's largest experience. So I think today it's not available in the US, it's not FDA approved, and potentially going forward in the appropriately selected patient, it certainly I think will have a role, primarily because it's non-invasive. The potency outcomes from HIFU in the data I've looked at are not the best. I won't expect it to be the best. About a 60% potency outcome rate for definitive treatment of localized prostate cancer. But at least in the US, it's not available today, and I don't foresee it being available for another good 2 or 3 years.
Adding to Dr. Gill's comment, yes, HIFU seems like quite a good technology, and the initial report mainly comes from Europe. It's quite good, no doubt about that. But as a radiologist, and also a few of my patients went to other country for HIFU, the most important issue here is that the patient selection. And the prostate size, prostate volume is very important, whether you are a candidate or not. Okay, they cannot ablate entire prostate when your prostate gland volume is 60, 70, 80 like that. But sometimes I saw patients like that when having a HIFU. Number 2 issue here is that most men, unfortunately, because of they had a chronic prostatitis, comes with quite an extensive calcium deposit within the prostate. As you know that ultrasound beam reflects sound beam back, okay, because they cannot penetrate through the calcium. So heat would not reach beyond. All right, so I saw one patient that I told him that's not a candidate because he had extensive calcification, but he ended up with a HIFU, and then I repeat biopsy 6 months later, showed a total failure. So patient selection is extremely important. And also that it comes with a voiding problem. So I think it's their protocol that they are performing TURP beforehand to every single patient to prevent urinary obstructive symptoms. And then in the future, I see that definitely role, okay, with some technical improvement, especially we are going towards the more of a localized focal treatment. Right now, cryo is used for focal therapy. We might be able to utilize HIFU technology too.
Okay. You want to say something, Steve?
I would add to the issue of patient selection, which is very, very important. Always be aware of the need for the selection of an artist. Just as we learned with radical prostatectomy, just as we've learned with cryosurgery, outcomes can be tremendously different based on the talent of the technician, be he the surgeon doing the radical prostatectomy or even the radiation oncologist. There is the human factor that's so important. The half dozen patients that I have seen that have gone to basically the major players in the world of HIFU in Germany have all done well, but again, it was patient selection and going ahead and telling them that they were in the hands of good people. And yes, they all ended up either with TURs before or after the procedure.
Do you want to share the name of that group in Germany? If you think of it later,
Was it Klasny or?
So Christian Chaucy
Yes.
in Munich has done over about 2,500 patients. He's going to be coming to USC as an international professor on our faculty. He has retired from there now. And to add further to what Dr. Ban and Dr. Strom was mentioning, the specifics are for prostate size, anterior-posterior diameter, it has to be 25 millimeters or less for the HIFU to be able to ablate it. This is for the EDAP machine, and for the other machine, the US HIFU, I think the number is 35 millimeters. So therefore, doing a TURP and taking out a bunch of the prostate, and then they use a rectal balloon to compress the prostate to decrease the anterior-posterior size so as to be able to ablate it. I mean, the fundamental fact is that high-intensity focused ultrasound will kill as long as it is accurately focused and covers the entire tissue. It can get the job done. More data are clearly needed.
Great, thank you. This is a general question for everybody. Can prostate cancer spread if the PSA stays fairly constant?
Definitely yes. PSA is not always a good marker for progression. So most definitely. So for men who, for example, are on active surveillance, those patients need to consider regularly having detailed prostate biopsies to assess what's going on with the cancer. So you can't hang your hat on the PSA. I think PSA is a terrific marker in men who have had primary therapy, surgery, radiation, and then you're following the PSA afterwards. But that being said, it's not a perfect marker.
There's in the patients with advanced disease, higher Gleason scores can transform to a PSA negative form, which is very aggressive and can happen. So that's one other example. But when you think of the active surveillance circumstance, by definition, the cancer itself is a small part of the volume of the prostate and a small contributor to the total PSA. Compared to changes that might be occurred with prostatitis or prostate injury. So that is a setting where you would not expect rationally that PSA shifts would always be due to the cancer. And the cancer might double without causing a change in PSA more dramatic than an episode of prostatitis might.
Dr. Strum?
One of the things that I don't think we physicians have learned from some of our teachers, as far back as Joe Osterling and also Alan Parton, but especially Tony D'Amico, was the importance of what Tony called combined variable analysis, which basically equates with if it looks like a duck, has feathers, swims and quacks, it's probably a duck. So to put all your eggs in one basket with one particular input or variable, for me, in any biological system, doesn't make a lot of sense. Getting more input from the DRE, from the PSA, from the pathology, as an ex-pathologist, I think is a very valuable concept. Using other tools, such as imaging tools, could also be something else that could be utilized in this setting. But again, it's not an all or none phenomena, it's another part of, another aspect of understanding the assessment, the status of the patient.
There are also some new genetic tools coming out as well from a number of different companies where they can do various studies on the cancer and start to look at if the cancers may behave more aggressively, for example, differentiating between different forms of Gleason 3+3 prostate cancer. So those are on the very near horizon.
The names of those tests are?
I'll get right back to you on that.
I know.
There's one made by Orion. There's one that Orion
That's
does,
the one I was thinking,
Aureon.
Yeah.
And there's another, which I'll let you know in a second.
There's also gene input now that's becoming commercially available that I know Bill's been involved with, but there's also like BRCA2, BRCA1 analysis. There's something that I've been doing with Helmut Bonkoff in Berlin, Germany for close to 10 years, which is a very, very comprehensive immunohistochemistry panel looking at what the prostate cancer likes to utilize for its growth as either good prognostic findings or bad prognostic findings. It's a battery of about 12 different immunohistochemistry tests, which I think are very useful. Can also allow you to develop.
Where would that be available?
Well, right now, it's really surprising that a single pathologist who is an internationally acknowledged expert in prostate pathology is doing it, and no major academic center is doing it. But it's Helmut Bonkoff in Berlin, B-O-N-K-H-O-F-F, and he'll do this on paraffin blocks from the prostate biopsies or from a patient that had a radical prostatectomy. And I can look at things that, there are some things that we have seen together that are almost invariably overexpressed in terms of being present in almost all patients with prostate cancer. One is an enzyme called FAS, fatty acid synthase, which gets into really issues of carbohydrate metabolism and the need to stress the importance of carbohydrate restriction for men with prostate cancer, and I would guess with women with breast cancer. It looks at things like P21 and P27. Things that can be modulated with the use of vitamin D. It will look at COX-2, which you can use as a target of therapy with COX-2 inhibitors, dietary and also prescription, and it goes on and on. So I think these are valuable tools. Again, it gets back into the concept that status begets strategy, that understanding the nature, the biological nature of the individual's prostate cancer opens up all kinds of opportunities to manipulate milieu factors and other driving forces that stimulate prostate cancer growth.
Yeah, the other company is called Myriad, Myriad. I suspect within a couple of months they'll have a product which is FDA approved. And this is a good company. They also make the breast cancer screening gene as well. They also discovered that. Myriad.
So Myriad and RN are the two commercially available ones that I'm aware of that are being looked at.
I got one more caveat with regards to the question about low PSA, or not using a PSA solely. One must remember to interpret the PSA in the face of a low testosterone level. So if you have a low PSA and yet you have a low testosterone, the PSA is even less reliable in terms of the cancer volume. So.
Also, I need to throw in this thing because I feel like the PAP has been a battered test with the advent of the PSA, which I truly love. But the PAP, there's peer-reviewed literature that shows that men newly diagnosed with a PAP of 3 or higher have a much greater risk of failing either radiation or radical prostatectomy. So the prostatic acid phosphatase should not be discarded. It does provide information.
Simple, cheap, available at all testing places. Yeah. So this PSA question is exceedingly important. So we've got this love-hate relationship with this tool that has really revolutionized the whole field of prostate cancer, but we're testing its limits, and research is going forward to try and enhance, learn more about it, and then learn supplemental tests that have been discussed here. Such an important topic. Any other comments? We'll move on to the next question. Next question gets asked every year, and it's an important question. Can the process of doing a biopsy spread cancer since the needles are penetrating the cancer? And again, this is for the whole panel here, if anyone has any answers to that question.
Well, to my knowledge, there is no evidence to support the myth that prostate cancer may be spread by needle biopsies. I personally am not aware of any study.
Well, I agree with that, and I'm amazed. It came up in our active surveillance session, and I don't hear the question in Virginia. We only hear it when I come to the West Coast. But Paul Lang, I think, did this interesting series of studies of men who would otherwise be eligible for radical prostatectomy and found prostate cancer cells in their bone marrow in a high proportion of cases. When the prostate was removed, those cells disappeared. So what limits the spread of prostate cancer aren't the cells leaving the prostate, but the fact this cancer has such difficulty setting up housekeeping in various places. So you wouldn't expect, if the biopsy did lead to a shower of cancer cells in the bloodstream, you wouldn't expect that to change the natural history of the disease. It's the nature of your cancer, not the spread, that makes the difference.
Go ahead, Duke.
Yeah, we had the same question during our active surveillance format. Dr. Meyer just explained nicely. And then actually, as a radiologist, I kind of searched the literature whether or not there is an even case report that cancer was seeded through the needle track. None in prostate. There are a few reported cases with percutaneous lung biopsy and also breast biopsy, but not with prostate cancer. Okay. I'm just to repeat that because some of you already heard that during our session is that I got this question over again only when I came to California from Michigan. So I called my mentor, Dr. Lee, said, Fred, give me let me know what you may know better than I do, but why you got so many questions of that? Do you have any answers? His question was, Duke, you are in La La Land. La La Land.
Mark, I would only add, I think that some of this could be attributed to back in the late 80s when there were about 2 or 3 retrospective reviews of patients who had undergone TUR. And they reflected that those individuals seemed to have a higher risk of developing distant metastases after TUR.
Explain a TUR.
Transurethral resection of the prostate.
It's to help men urinate, the Roto-Rooter.
Just right before the HIFU
Yeah,
we talked
go ahead,
about.
sorry.
But later on, about 5 or 10 years later, in the early to mid 90s, those institutions reviewed their data, and other institutions tried to confirm what was being seen, and the results were negated. So I think people are always concerned whether it's prostate cancer or other malignancies, whether stirring up the cancer with a biopsy will will aggravate things. Now, what I try to reflect to patients is that they have active blood flow through that area to begin with. And there's nothing stopping cancers from migrating on their own.
I like to tell patients that in the good risk group, the cure rates with seed implant surgery and whatnot are over 90%. All of those men have biopsies. So if cancer is being spread by the biopsies, it must be quite infrequent.
Mark, this discussion raises a possible major opportunity. Along what Snuffy said, there's a need for a critical mass of tumor cells in the circulating blood to set up a metastasis. But there's no question that prostate biopsy and TUR of the prostate does release cells into the bloodstream. Now with the new gene expression profiling that we have, and with tests like circulating tumor cells, wouldn't it be kind of neat if we could take advantage of that by collecting blood after prostate biopsy or after TUR and utilizing that circulating tumor cell methodology to then be able to do gene expression profiling on the actual patient's tumor cells?
So sort of put the prostate in a blender and find what comes out in the blood.
Yeah.
All right, now this is a controversial question too. Thoughts about testosterone replacement in people that have been previously treated with surgery or radiation and have been continuing in remission? Yes, so if someone has, as men get older, their testosterone levels start to drop, people can get hypogonadal. We're seeing ads on TV now for low T. And what about a prostate cancer patient that's had previous treatment for prostate cancer, such as surgery or radiation?
Again, it's status begets strategy. If you show in that patient that they have a flat PSA graph, if there's no evidence of active disease, at the very worst, testosterone is an excellent stress test to determine the status of the patient's prostate cancer. So I have definitely had patients on testosterone replacement therapy, post-RP, who've had undetectable PSAs, who've been monitored while on testosterone replacement, post-radiation, who've done quite well. I've seen patients who've also been treated with testosterone where the elevation of PSA has led to a diagnosis of prostate cancer. They were undiagnosed. They were placed on testosterone replacement therapy. Their PSA rose. It prompted a biopsy, which then revealed prostate cancer. And interestingly, in those patients, when the testosterone replacement therapy was not reduced, but stopped, their PSA dropped back down to where it was at baseline, and all imaging and pathology confirmation of prostate cancer was no longer to be found, even with repeat biopsies.
I think it's really important to use common sense here. There are tables and nomograms to tell about the cure rate. We know that a certain number of years pass after surgery or radiation, the risk of relapse drops off. So if you have someone 6 years out from radical prostatectomy or radiation with good prognostic factors, and they have serious health consequences of a low testosterone, it makes perfect logical sense to handle this. I'll give you two cases that were crystal clear. One man was severely depressed with a low testosterone and had 2 suicide attempts that failed. And testosterone reversed that depression. And so in a certain sense, the cancer wasn't even remotely close to a survival risk compared to his mental state. And I do see people with, low testosterones are really dangerous for people with prediabetes or diabetes mellitus. It really complicates the management of those diseases, and that's one clinical setting where I'm very aggressive at giving testosterone replacement to folks.
I think there was a paper published by Morgan Taylor, and then he reviewed all the articles regarding this issue. And his conclusion was that the testosterone replacement therapy there is no undue risk of tumor recurrence or progression. That was his final conclusion.
Yeah, so we take that on a case-by-case basis. Obviously, I think that in patients who we think would benefit from having more normal levels of testosterone, and we do give it, we prefer to use the gel formulation as opposed to the injection. With the injection, treatments, which men do every 2 weeks or so, you really get vastly fluctuating and very high levels of testosterone right after the injection. So I think the gel is a better formulation to use. And then the key thing is to follow testosterone levels once you start it. Just bring them into the physiologic range, and that's the best way to do it.
Okay, so pretty much a consensus that if you're selective and careful, it's a reasonable thing to do. The next question, I think, is comes out of Dr. Mulhall's talk yesterday about using prophylactic measures in men who undergo surgery or radiation to try and preserve their sexual function. So the question is it advisable to start prophylactic therapy in everybody before surgery, radiation, or hormone treatment?
So let me take the surgical part of that question. In folks undergoing prostatectomy, pre-operative PD5 inhibitors or other treatments to embellish potency are necessary only to the extent that the person becomes familiar with the side effects of it. So for example, someone wants to have Viagra, if you would recommend somebody to take a Viagra before surgery, that would be to get the person familiar with the side effects of it, the headache, the blue lights and stuff like that. I'm personally not aware of any data where preoperative medications will improve post-operative potency. However, penile rehabilitation early on after surgery is clearly beneficial. If you don't use it, you lose it. So as far as I'm concerned, we start actively on the penile rehabilitation program after surgery, which is literally a week after surgery when the catheter comes out, is when we start the patient on Viagra or Cialis, and again in an escalating dose per the response of the patient. If the outcome is not as good as one would like, then one can certainly add the penile pump that adds to the blood flow to the penis, and so a combination of things. But the bottom line is to wait. I think the one bad thing would be to wait the 3 months, 6 months, 9 months for potency to return before you start adding these things. I think one should be proactive immediately after surgery, and by that technique, whether you do it once a day or twice a day dosing, etc. Some studies, certainly from Francesco Montorsi, who was the first one to show this from Milan, indicated that the group that had active penile rehab by whatever means had fared better in earlier return of spontaneous potency compared to those who did not.
And I would add that in terms of radiated patients, even 5-10 years ago, there were randomized trials that showed in patients who had developed erectile dysfunction with any form of radiotherapy, whether it was external beam or implant, if they were randomized to receive Viagra post-treatment, their recovery was approximately 50 to 75% of patients who received a placebo. A more recent paper, and it could have been from the group at Memorial, has shown that earlier use of PD5 inhibitors yield better results. The concern is that over time, radiation therapy has a developing insult or trauma to the endothelium and the microvasculature around the penile bulb. So whereas I agree with Dr. Gill that there is no definitive data to suggest a benefit to giving it before treatment, I think that's the next extension of investigation. That at least for radiation therapy patients where we're not dealing with having an operation, that if patients who are concerned and want to invest themselves in optimizing their likelihood of erectile function, that to initiate therapy even before the implant or before the external beam is of benefit to them.
Okay. Dr. Lam, can you come on hormones and?
Sure. So, with the concept of hormone therapy, there's actually no, when you're on hormone therapy, there's less of a direct physical insult to the penis. But when you're on hormone therapy, your libido is decreased significantly in most men, and as a result, you tend not to have spontaneous erections as often. You have less of a desire to even have intercourse. So you end up having the same practical effect as in, if you don't use it, you lose it. So in men on intermittent hormone therapy, we do advocate using prophylactic Viagra or Cialis in the same situation as after surgery. And number one, to preserve potency. Number two is to prevent penile atrophy and shrinkage.
Okay, go ahead, Dr. Stone.
We had patients, Mark, when we were in practice together, who even on ADT, with the help of these phosphodiesterase inhibitors like Viagra, were able to get erections. There are multiple components to male sexuality. Some may be these chemical agents, others may be other issues such as the circumstances, sensory input. There was an excellent paper that is seldom quoted from the Journal of Urology on the use of pornography in men who had had orchiectomy, men who had had actual surgical castration, where they were shown pornographic material, which I've been trying to obtain, by the way, that indicated that in 25% of these men, they were able to get erections suitable for vaginal penetration. So it depends on what turns you on, whether it's a chemical, or whether it's dirty talk, or nice pictures, or whatever.
Any follow-up on that one, guys? All right. Okay, a more mundane topic. Do any of you adhere to or believe in chemosensitivity testing of the tumor cells?
If no one's
No.
willing, if no one's willing to take that, I will. My cousin, Ann Hamburger, was actually the person at the back east. And,
Maybe you ought to tell them what chemosensitivity is. 'Cause
Yes.
we haven't really talked about it, so. I'm
So
sorry. Yeah.
chemosensitivity is the ability to take tumor cells, live tumor cells from the patient, and incubate it with various substances. That could be chemotherapy agents, it could be natural products, to determine cell kill and possibly sensitivity. And Ann Hamburger worked, this is really a true story, Ann Hamburger, who worked with the cell culture laboratory, then went off to Arizona and worked with Sidney Salmon. So it was called the Assay of Hamburger and Salmon. Okay. Sid Salmon was a brilliant medical oncologist, great guy who unfortunately passed away from pancreatic cancer. Dr. Tisman and I actually did a chemosensitivity assay as far back as 1975. I had many patients, even before the days involved with prostate cancer, where the chemosensitivity assay identified drug therapy that I would never have considered, and yet in the clinical patient was borne out to show dramatic responses. One patient with ovarian cancer that was extremely sensitive to adriamycin, we actually treated, who went into a complete remission with no evidence of ever having a recurrence with 10-year follow-up. It really gets into looking at, again, who's doing the chemosensitivity assay. In California, there are two outstanding medical oncologists, Bob Nagurney and Larry Weisenthal, who have their own dedicated chemosensitivity laboratories. If you find drug resistance, they call it extreme drug resistance, or EDR, you can at least say that that chemotherapy agent is not going to be effective in that patient. If you find sensitivity, there may be corollary with that particular agent showing efficacy, but at least there's one major value, that is to eliminate drugs where there's a very, very minimal chance of them being active in the patient's treatment. So I think it's perplexing that the literature remains controversial, and some of the meta-analyses tend to negate the value of this. I do think it is a valuable test.
There's a new iteration on this that measures gene profiles that dictate chemotherapy sensitivity, and Caris DX in Texas has been very active in this. The problem with prostate cancer is where you'd like to do this is in a bony lesion, and sometimes it's hard to get a good tumor cell population out of a bone lesion by biopsy. But I have one case of a cancer of the Cowper's gland that there's 34 cases in the world literature. And 5 years ago, the folks at Mass General had said there was nothing more that they knew to do and discharged him. And he's been alive for 5 years now with 4 different rounds of gene testing and chemotherapy based on the gene testing results. The latest one is Gleevec, expresses the gene that dictates Gleevec responsiveness. And his tumor is melting rapidly during the first month on Gleevec. So I think the issue with prostate cancer is more of a technical one. If I could find a reliable way of getting a sound tumor population not contaminated by other cells out of a bone marrow lesion, I would use it more often.
Okay. Got a few other good questions here, but why don't we go ahead and present that first case, if you can throw up the PowerPoint slide over there. This first case, this is a newly diagnosed guy, so we don't have any follow-up. There's no right or wrong answers here. I thought it'd be good to present sort of a garden variety, what we call an intermediate risk prostate cancer patient, young enough for any of the different alternatives, and see if our panelists would develop any strong opinions or if they'll just all be the usual tapioca, he can do anything. So jump right in, guys. This is something we see every day. 2 cores positive, not excessively. On the young side by prostate cancer standards, we don't really have a PSA velocity. His PSA density is probably not totally out of range, but a little bit on the high side. Prostate volume's reasonable for his age. So he, I think many would say, is eligible for all options. Is that true, or is there one better way to go? Let's assume he's a sexually active person who values his quality of life and wants to keep potency if possible.
Well, I would say, in addition to surgery and radiation, this guy should consider focal cryosurgery as an option.
You want to elaborate on that a little more, Dr. Morrison?
Well, he's got a small lesion. Gleason 7 and above, I don't like to do active surveillance on, and I think the literature supports that. But the cancer is small, and the capsule's not involved, so I presume from this information, it's probably in the middle of the gland and would be accessible to cryosurgery. So that's an option not often considered, but associated with good sexual function and retention.
Okay, go ahead, Duke.
Well, first of all, based on what we have here, he has a Gleason 7, 3+4 is not 4+3, which is good. Because of Gleason 4 component, we cannot classify his cancer as a low-risk disease. So at least intermediate risk disease, where the 59-year-old man needed some treatment rather than active surveillance. And then most of the known conventional treatment like surgery, radiation could be maybe too much overkill. But anyway, focal cryo should be considered as well. But I have some problem with knowing that only 2 of 12 cores positive from the left. Where the 2 comes from? One from the base, one from the apex, or close together? Okay, based on that, he may or may not be a good candidate for the focal cryoablation. If it's a relatively large volume tumor, all the way down to the apex, near the external sphincter, then he's not an ideal candidate for the focal cryo. So another point here is that it could be all understaged. You are just totally reliant on endorectal MRI, shows no extra capsular invasion, but he may have even much bigger cancer, may have extra capsular invasion. So before he make up his decision, I think he might need a color Doppler ultrasound evaluation.
Okay, go ahead, Dr. Strong.
About 14 different comments. With a Gleason score of 3-4, I would want an expert pathology review, and I would absolutely suggest that in the year 2011 almost, I think it's ridiculous that we haven't mandated that every pathologist indicate the percentage of that secondary component, grade 4. I don't know if all of you know how the Gleason score works. You have a primary and a secondary grade. The 3 is primary grade. In this case, the 4 is secondary grade. The secondary grade can be anywhere from 5% to 49%. People like McNeil and Stamey from Stanford and others show that the amount of grade 4 and grade 5 dictates, for the most part, the aggressiveness of the prostate cancer. I want to know, is this 4% grade 4, or is it 49% grade 4, or somewhere in between? Because that will affect the natural history of this disease tremendously. And probably a 3-4 with a very small amount of grade 4 probably will act more like a 3-3. Number two, the calculated tumor volume for this patient is not that great. He may end up being a candidate, despite the published studies, for proactive integrative care. I would not discount that, despite the fact the criteria was for a Gleason score of 6. I would bet you that in years to come, if we look at what I call Gleason differential and the amount of the grade 4 or 5, that if it's 15% or less, they'll all act like Gleason score 6s. So he may be a candidate for a proactive integrative care or active surveillance type of approach. Also, I would not throw out the value of routinely, in a newly diagnosed patient, getting a prostatic acid phosphatase and making sure that it's less than 3. Otherwise, it's an adverse factor. And I wouldn't toss out the idea of doing an extensive immunohistochemistry panel to better define the nature of that Gleason, of that patient's prostate cancer. Does it show a lot of upregulated adverse prognostic findings to suggest this would be more aggressive or less aggressive?
Go ahead, Duke.
Yeah, add to Dr. Strom's comment, yes, it is very important to have a percentage of Gleason 4. 3 plus 4, but 4 is only 10%, equals 7. Is probably close to 6 rather than 7. In the case that, and also, if a transrectal ultrasound can identify where cancer's index tumor at least is, that is somewhere in the middle level, somewhat far from neurovascular bundle or seminal vesicles like that, then he could be a candidate for an active surveillance.
Okay. So,
Also,
Yes,
Duke,
go
your
ahead.
color Doppler ultrasound should help to identify the high-grade Gleason components, 4 and 5. The MRI studies should also do that. If the spectroscopy were abnormal, there was no mention of spectroscopy, but that will identify lesions that have a high choline to citrate ratio, which usually is correlated with higher Gleason scores of 8, 9, and 10. So you have additional biologic input. Status begets strategy.
okay, then, go ahead, Dr. Gill.
Well, I must say I'm surprised a little bit. What we are talking about here is a young individual, number one. This guy, I'm assuming he's healthy and has no
Completely
comorbidities.
healthy, completely healthy.
59-year-old guy has 30 more years of life ahead of him, number one. Number two, this is an intermediate risk cancer. Make no mistake about it. The aspects alluded to earlier by other speakers about the percent of Gleason 4, etc., are important, but not definitive. There are no data at this point that can tell you if the Gleason 4, which is a secondary score here, okay? So by definition, it is not the primary. Gleason 3 is the primary score. I just want to stick with the well-published series and the published data. So the facts of this case are the following. He has 2 positive cores on the left side, okay? If he were to be rebiopsied, so this is a young patient with intermediate risk disease. Currently, on the right side, right lobe, there are no positive cores. If this patient were to be rebiopsied right away, i.e., if active surveillance is being considered, there are not too many groups who would actually take this guy for active surveillance. But let's say it is. You need an entry biopsy. In other words, you need to have a rebiopsy before you relegate this patient to active surveillance. A rebiopsy, there's about a 40%, here are the data, there's a 40% chance that the rebiopsy within a month of the previous biopsy is going to show the same Gleason 3 plus 4. 40% chance. There's a 25% chance the rebiopsy is going to show an even higher disease than listed here, Gleason 4 plus 3 or whatever. And there's a 20% chance that the rebiopsy is going to show no cancer. These are just the data. So in other words, the needle biopsy is not a 100% test. This is irrespective of whether it's MR guided, ultrasound guided, MR fusion guided, etc., it is not a definitive test. That's number one. Number two, a study from Hopkins looking at 100 patients of this kind, which is one side, one lobe is completely negative. So everybody understands that, right? In this patient, as shown here, the right lobe has no cancer on needle biopsies, yes? If this guy underwent a radical prostatectomy, 35% of these men will have cancer in the right lobe. Needle biopsy said no cancer. 35% will have cancer on the right lobe. 20% of men will have high-risk cancer in the right lobe, unbeknownst to us. 15% of men will have extracapsular extension on the side of the lobe that the biopsy says doesn't even have cancer. 11% of men will actually have a positive surgical margin on the side where the biopsy is telling us cancer doesn't even exist. So in other words, I think that to start talking about active surveillance and focal therapies for folks with intermediate risk disease who are young, the onus is on the physician to give reasonable reassurance to the patient that the person is not harboring more serious disease than has been revealed by an initial biopsy. And what would I do if this patient came to me? I would lay out all these arguments. I would talk to the patient regarding his overall fitness. I would talk to him, figure out what his personality is. In other words, is he, how compliant he is, what is his overall aspect. But in the fundamental analysis, again, I'm a surgeon talking and I bring that bias to the table. I'll be the first to admit. But fundamentally, this is a young, healthy, active patient with intermediate risk disease, up to 30% of one core. And my God, if this is not a guy who would be an excellent candidate for a beautifully performed, nerve-sparing prostatectomy, whether it be done open or robotic, is dealer's choice. It depends upon the excellence of the surgeon. It depends upon the skill level and the experience, okay? But, I mean, in this kind of a patient, we are talking a 2.5 hour operation. We are talking a possibility of full continence up to 85 to 90% by 6 months. We are talking potency outcomes, given that he has excellent potency up front, potency outcomes of 86% with or without Viagra at 1 year. And the chances of getting negative margins and getting all the cancer with monotherapy of 95%, all published data, if it is confined to the prostate, 82%. If it is not confined to the prostate, would be my...
Finally, some passion. This is great. Finally. Did we wake everyone up? All right, I want to keep this energy going here. So let me just propose very briefly.
Okay.
I'm sorry. You want to go first?
Well, I would point out I didn't talk about active surveillance, but in defense of those that did, the numbers you're citing for failure are the very reasons we recommend endorectal MRI and color Doppler. It's to get around the inadequacies of a standard biopsy. And I've sent a whole series of patients to Duke who then had radical prostatectomies, and your numbers don't remotely approximate what I see with modern imaging studies.
So let's start
The second point I would like to make is the very reason to avoid surgery is he's a young man, because you're condemning this man to 30 years of not normal sex. The potency figures underestimate the impact of surgery on male sexual function. The sex act is never again the same. Urine control is never again the same. You might be fine sitting in a chair, but if you're jumping up and down on a trampoline, you're going to leak. So the very fact that this man's going to have to face 30 years of an impairment is the reason why we need to be very careful that the surgery is needed, and that's why I would go and do the things that Steve, I think, did an excellent job outlining, the staging procedures that should be done in this man. This is a great case because it isn't an ideal active surveillance patient. It's not, it's right on that edge where we all argue in the halls.
Let me ask this question because it was raised by Dr. Strum, I think, that if his biopsy was regraded as a 6 by someone like Epstein, and because that was there's maybe a 10, 15%, 20% chance in the community that they may regrade him lower, and then he had a follow-up biopsy in the staging, then maybe he would, you could say he fits into the more classical, but it's a good case for this kind of on the edge. I'm glad you guys are jumping in with it. So
To throw a little passion in here, I have nothing at all contrary to what. Is it okay for me to call you Indy? Is that your nickname?
Indy is right, yeah.
I've always wanted to call someone Indy after those Indiana Jones movies.
You would not be the first.
I saw that on your email address, and I got really excited about doing that. So I have nothing contrary to say to what my colleague has said regarding being able to present this man a chance to be cured and not have this burden of prostate cancer resting on his mind and on his body. I've got nothing at all to say in contrast to what my colleague to my left, who I've known for so many years, has said, that once you remove that prostate by surgery, by cryo, by radiating it, by sauteing it, whatever, you change the man's sexuality. You do, and we don't. But if you inform the patient of these things honestly, I think that's a different scenario. If you don't, then I think that you really are an embarrassment to the medical profession. What I would hope to see would be routine review of pathology by experts. And as an ex-pathologist that was at one time focused totally on lymphomas like Hodgkin's disease, I could not believe the discrepancies in the pathology involved with the reading, even by so-called experts in the world of hematopathology. Because of that past experience, I'm very sensitive to the need for expert pathology review in prostate cancer. I've actually had a patient who came to see me the night before surgery, and I said, I'm not a pathologist with expertise in prostate cancer, but I'll look at your slides. I could not find anything that even remotely looked like prostate cancer on his biopsy slides. Had them sent to an internationally acknowledged expert who said there's no prostate cancer here. And that man came back to see me year after year just to thank me for having been spared a procedure. So I could not emphasize more the need for an expert review where there's detailed discussion of the pathology findings. So I do think that there's another thing that we forget, and that's the tincture of time. If this man is newly diagnosed, how do I know what his lifestyle has been coming into this diagnosis? Maybe he's a major consumer of long-chain fatty acids, alcohol, and excessive carbohydrate intake. Maybe he's an obese 59-year-old that's got an adipose tissue that's releasing pro-inflammatory cytokines that's feeding into his prostate cancer. There are a lot of different issues here. Do I have anything to lose by changing this man's lifestyle, by correcting a lot of his internal medicine issues that may alter the natural history of this disease? What about looking at his bone integrity and seeing if he's got overly active bone resorption? So all of these play into the equation. So I don't think that we have to rush to do something, but I do think we have to educate the patient and communicate with the patient.
Okay.
Oh, and Mark, I don't want to be left.
Yes, go ahead, jump in.
So I do agree with, all the comments that have been made by the panel, but I didn't want to feel left out as the sole radiation oncologist here. There are many debates, and I'm going to focus strictly on radiation therapy because all the other esoteric issues have sort of been beat together beaten by a club here. Is that when you're talking about the young patient, a patient under the age of 60 who are told they absolutely have to have surgery, and I don't arm wrestle with the surgeons regarding the younger guys because one could argue, at least hypothetically, that what the results are going to be are 20 or 30 years later. But just to bring out 2 points. Number one, there are now about 4 or 5 different articles from different institutions showing that the younger patients who get radiotherapy generally implanted do not do worse than the older patients. In the last 2 months, there are now 2 additional papers, one from the Princess Margaret, one from Greg Merrick in West Virginia with 10 and 12-year data to show that these results continue to be excellent and durable out long term.
And that's for the Gleason 3+4s.
Gleason 3+4s. The one I will quote is, and to talk about 2 topics, is that people frequently are told they have to have with radiation hormone therapy or else they won't be cured. A recent article about 700 men with intermediate risk disease from Stock and Stone at Mount Sinai looked at 4 3s and 3 4s who all got external beam and implant combinations, and many would debate that for a 3-4 with 2 cores you could do a seed implant alone. Their 12-year data is 92% without hormone therapy. So, which if you gel together the patients who have surgery, who have clear margins and positive margins, and put them all together, it seems to be statistically of equal efficacy. But I think that if someone wants a seed implant alone, you have to go to someone who is an artist, like Dr. Strom would allude to. Patients who have suboptimal implants have outcomes that are, for Gleason score 7, have results that are about 20% less. It really makes a difference when you have intermediate risk patients have an excellent implant if you're going to do it alone. So in this patient, I agree there's a wide variety of options available, but as far as my end of the aisle is concerned, I don't think the patient needs hormone therapy. He could consider implant alone or implant external beam. I think those results have, over time, been shown to have better durable data than IMRT or protons, actually.
Well, finally, someone said something they can't do, so we can't do hormone therapy.
I don't
Everything
think,
else is on the table but hormone therapy. Is that agreed? Wow. All right. Okay, so the next question, and then we'll do, I think, one more case after this, but I had one question I think it's got to be asked, is once you've made the rounds and talked to a surgeon and a radiation therapist and oncologist and receiving multiple different opinions, how do you find a tiebreaker, or how do you finally decide what to do when you have conflicting expert opinions about what's the best thing to do? Is there a way to get past that, or are you totally on your own?
I had a patient who used a dowsing rod. He would line up my prescription pills in a line and would douse each one and decide which ones to take.
Go ahead.
I don't know if I heard your question. You're saying the patient has had all these different consultations?
Well, you went to the surgeon wants to do surgery, the radiation therapist wants to do radiation, the oncologist wants to give him hormone treatment.
You know, I try to do a randomized study like that, actually, and it turns out that some patients are more comfortable with one type of approach than others. In fact, Fred Lee used to recite the poem by, I think it was by Robert Frost, correct me, Duke, you would know this, called Fire and Ice. You know, some prefer fire, but I prefer ice. He was promoting cryosurgery. Well, believe it or not, there are some patients who just say, I just don't feel good about the idea of radiation. Or some say, I don't feel good about having surgery. So you have to get a sense from the patient what their mind, what their emotions feel comfortable with, even after they've been educated. And that may affect how well they do. And then you need to present to them. For example, there's something that's very important that's missing from this history, and that is lower urinary tract symptoms. If I have a patient that comes in with severe lower urinary tract symptoms and a high AUA score, I'll tell them a radical prostatectomy is going to give you a whole new world in terms of a new urethra. You're going to be able to pee like you did when you were much younger. That's a major plus. And if you have radiation, it's going to be, you will be having your symptoms get worse. So that's the reason for it. The people up at UCSF have pointed out that the length of the membranous urethra may have a great deal to do with how well the patients do in terms of incontinence post-radical prostatectomy. That may be a downside.
Measured on ultrasound
I
and
measured on MRI. So if their membranous urethra is 12 millimeters or longer, they're going to do better in terms of radical prostatectomy. That's published by that group, Coakley and et al. So there are a lot of different nuances regarding what may lead the patient. What do they feel comfortable with? What are their lower urinary tract symptoms? What's their availability to a talented surgeon? To me, people who are really, truly the artists in the world of radical prostatectomy have always been the ones that I've tried to refer to. You're fortunate now. You've got Dr. Gill, who's come from the Cleveland Clinic, yes, with a huge amount of experience. In the past, when I was down in LA, I only had 1 or 2 people in LA. I won't mention names. I had one at UCLA that I thought was truly an artist. I had one in private practice who is here at the meeting, who I can mention, who I thought did wonderful radical prostatectomies with very low incidence of incontinence. When I moved up to Ashland, Oregon, my local patients I would refer either to Peter Carroll at UC San Francisco or to Paul Lang. I happen to be one of the few docs and medical oncologists that truly admires and respects Pat Walsh. I like the guy. I know he's brazen, he's tough, he says what's on his mind, but he's an artist. So I think that we have to know, does a patient have access to an artist? Maybe he doesn't. Maybe his insurance won't cover that. The same
so
thing
maybe the quality of the doctor is more important than the actual treatment.
The one area that I think in my life that this is gigantically important in terms of prostate cancer, not only surgery, but I'd have to say, and I'm not trying to butter up Duke, is cryosurgery. It's a world of difference between sending a patient to Duke Bond for cryosurgery as opposed to Tom, Dick, or Harry. Yes.
Amen.
You know what they say? There's an old saying, what do you call the person that graduates first from their medical school class? Doctor. And what do you call the person that graduates last from the medical school class? Doctor. So you got to look for the artist.
Well, I have to say that I'm trying to imagine the patient where hormonal therapy, radiation, and surgery would be equally good recommendations. And I'm thinking that the odds are high it's a medical oncologist who has an axe to grind. I would suggest you find a medical oncologist who doesn't have an axe to grind to give a more nuanced view of it, because these 3 modalities have distinctly different properties and uses, and you need the medical oncologist is great because they're not going to make money from surgery or radiation therapy, and if they truly understand the disease, they should be able to talk in an objective way about the advantages. I can't imagine the case where the hormonal therapy and radical prostatectomy would be equally
Well, that
contested.
seems to be what I'm hearing. Everyone seems to be saying anything but hormones. I haven't gotten any sense. Our surgeon is... Go ahead, Dr. Lamb.
I'll chime in here. So the way I ask our patients when they come to us with this discussion about what to choose, first question I ask is, what have you already scratched off the list? And oftentimes they'll tell me, I'm sure I don't want to do surgery, or I'm sure I don't want to do radiation for whatever reason. Radiation scares me, or I don't want to leak. So one question is, what side effect are you most scared of that you may get? Remember, you may not get it, but if you were to get it, which side effect will devastate your life? So and that often narrows down a couple of the treatments. The second question is, what does your wife think? And because this is it's a decision that I think both both the 2 people need to probably make together, because the partner will be suffering or dealing with a lot of these side effects. It's just not the patient. To be a little bit more thinking out of the box, if we were to consider hormone blockade, I do clearly tell patients that hormone blockade is not a curative route, but it is a very effective treatment to actually shrink the cancer and maybe turn back the clock to where, I tell patients they probably have had this cancer for 2 to 5 years. Maybe if we shrink it with hormone blockade to where the cancer was in 2006, and then do active surveillance, and make your decision later with regards to local therapy. And you know, if you start hormone blockade, and you could always see how well it works, and you may want to do a biopsy after a year of hormone blockade, and if there's actually no cancer on a biopsy, you can argue that there's so little cancer, maybe there's no urgency to do some type of local therapy. But you know, you have to go over the pros and cons of even hormone therapy, which has some side effects.
Dr. Botnick first.
I would just add to everything that, I mean, we as a medical community have dropped the ball in terms of offering an answer to patients of what may or may not be the best treatment. Again, everything could be the same. I mean, in breast cancer, you have thousands of women diagnosed every year, and you have randomized studies looking at mastectomy versus lumpectomy and radiation, lumpectomy alone versus lumpectomy and radiation, sentinel lymph node and lymph node dissection, sentinel lymph node alone, different types of chemotherapy, multitudes of randomized trials, and yet in the U.S. and in almost every country, there is not a randomized trial between any modality versus another, and that's probably because it's to the exclusion of the other. And I mean, there is only one there is a randomized trial that exists between seeds and radiation, seeds and surgery in Italy. 200 patients. That's all that could be mustered. We really have to look inwards to evaluate the best way to follow patients, and we have to sort of give up a little of our own biases to perhaps find out what may be the best treatment and there may be different levels of best treatment. It could be oncologic, and it could be quality of life and functional. But we do actually owe it to our patients.
Okay. Do you want to say something, Steve?
I love clinical trials. The problem is that some of them last so long that by the time they're nearing, not even coming close to completion, the technology has changed so dramatically. A good example of that is the advent of IMRT, in contrast to 3D conformals, in contrast to standard radiation, and even some nuances on IMRT. The same thing with surgical approaches to prostate cancer, evolving, all the time evolving with nuances. So it's and the same thing with staging, where there were apparently major advances being made, now slowed down somewhat, but some major advances. So it's not easy to do these gigantic clinical trials involving thousands of patients and be patient about getting the results while technology changes. The other factor that's also involved with treatment decisions in doctors is really related to the old quotation that if you put two doctors in a burning room, they won't agree whether to stay or to leave. So that you're always going to get differences of opinion. 2 years ago at the PCRI conference, I was asked by Mark to present the topic of primary androgen deprivation therapy as the treatment for prostate cancer. And I was astounded at that time to find out that in Japan, primary ADT or PADT was the most common modality in terms of treating prostate cancer newly diagnosed. So I think that that is an option for patients. It does give them time. You can look at the side effects from ADT. You can ameliorate a lot of those side effects, but it is an option. And I would ask the audience, by a show of hands, how many of you out there have had primary androgen deprivation therapy as your initial therapy? That's not a small number. And how many of you have only had primary ADT as your therapy? And how many of you have gone on after the ADT to have definitive therapy such as radical prostatectomy or radiation or cryo? It's interesting stuff. How many of you that have only had primary ADT are happy with where you are in terms of the status of your prostate cancer? Not as many as I would have thought, but not terrible. And how many of you are happy after you've had primary therapy with surgery or radiation with where you are in your life? That's what, about
Similar.
equal? Yeah.
It's been a great talk. We're running out of time. I want to leave everyone a chance to make any final comment if you want to say anything. Yeah.
So coming back to the question you earlier asked, what's a patient to do? I would hope that you would have the counsel of honest physicians who would not only tell you the positives about their particular expertise, but also the negatives. And I would hope that you would get consults from surgeons, from radiation therapy, from medical oncology, as all of our patients do. And then make a decision based on the information you've received and what works for you as an individual. Because clearly, oncologic issues are one aspect, the quality of life and functional issues are another aspect. Both are equally important. And you as the primary person has to figure out how much weight to give one or the other, and then go with your gut.
All right, if there are no further comments, I want to say one thing, that we're lucky to have all these artists here with us, and in answering that question, I would feel comfortable with defining any of the doctors here at the table as an artist, as most of these people are here in California, and this is going to go out and around the world and the country, and that's not practical for people who are not geographically able, but we're very, very fortunate through experience to know that these doctors are very, very good at what they do. So with that, I think we'll go ahead and dismiss the conference. So we'll probably be milling around here for a while. If you have any questions, feel free to come up. And thank you very much for a wonderful conference.